Welcome to this talk on vasectomy reversals. If you've been looking into getting a vasectomy reversal, you probably come across a couple different approaches to perform a vasectomy reversal. There's a conventional vasovasostomy, or VV for short, and there's a more complicated or specialized reconstruction called vasoepididymostomy, or VE. So this video is about telling you how do we determine which technique is required in your situation. I'm Dr. Ryan Flanagan. I'm a urologist and a trained microsurgeon in male reproduction. As I mentioned, there's two types of vasectomy reversals that can be performed. After the vasectomy, as you can see in this image here, there's essentially a gap or a point of blockage in the tube that carries the sperm. So we have to somehow reconnect the testicular side to the side that can carry it out into the semen. In a conventional vasectomy reversal, termed VV, we can simply reconnect the two ends of the tube back together again under a microscope. However, a second technique is called a vasoepididymostomy, VE, and this involves connecting the upper part of the vas deferens, or the tube, to the structure called the epididymis, which is attached to the testicle. In the conventional vasectomy reversal, what we have to do here is cut the two ends of the tube on either side of the vasectomy site to fresh, healthy ends. Then, under a high-powered operating microscope, about 20 to 25 times magnification, we can reconnect this tube back together again. We're using very fine sutures, typically smaller than the hair on your head, to ensure that we have a very nicely approximated lumen or open channel on the inside of the tube that the sperm can pass through. And then we use slightly larger sutures, but still quite small, to reinforce the strength of the tube on the outside. In the more specialized reconstruction, called the VE, basically this entails sewing one of the tiny little tubules within the epididymis, which is the storage site for the sperm, attached to the testicle, to the larger vas deferens, which is the tube that was cut during the vasectomy. This involves using those very small sutures again and connecting the side of the tube from the epididymis to the open channel or the lumen on the vas deferens. This is again performed under a high-powered operating microscope, approximately 20 to 25 times magnification. We then reinforce the outside to ensure that it's watertight to facilitate the best chances of sperm going back through the tube. So how do we decide which type of reversal to perform? Unfortunately, there's no clinical tests or anything on history that can tell us ahead of time which operation is needed. Therefore, it's really important when you're choosing your surgeon of choice that they're both comfortable with a regular vasectomy reversal as well as a more specialized VE procedure. So how we can determine this is at the time of the operation. We cut back the tube on the testicular side, just below the site where you had the vasectomy. There's fluid on the inside of this tube, and we look at it under a microscope. And the characteristics of this fluid then tell us if there's a blockage or not. So how do we determine which type of reversal is necessary in your situation? Unfortunately, there's no clinical tests that we can perform that will tell us which way we have to go ahead of the time of the surgery. Certainly, we can risk stratify and determine what the chances are and have somewhat of a prediction, but ultimately to determine which one we have to do, this is determined inside the OR at the time of the actual reversal. So it's really important when you're choosing your reversal surgeon that you have somebody that's capable to perform both a conventional reversal as well as a more specialized VE reversal. So why is this the case? Well, over time, since your vasectomy, your testicle has been producing sperm this entire time. Along with that sperm, there's a little bit of fluid. Now, this is typically okay for the body, and your body will reabsorb all this excess sperm, millions and millions. However, over time, the pressure does increase a little bit, and the epididymis, which is attached to the testicle, which normally houses all this sperm, gets under a little bit more pressure, and at some point, you can end up getting a rupture of one of those very small tubules, and if it ruptures, it can secondarily scar down and create a secondary blockage. If this happens, the conventional vasectomy reversal isn't going to work, and we have to identify that at the time of the operation and perform the more specialized reconstruction called the vasoepididymostomy. In this operation, essentially what we can do is we can bypass that secondary blockage by connecting the tube that's on the upper side of the vasectomy site, and we can connect that to one of the tiny epididymal tubules upstream of the blockage so that sperm can readily transport into the tube again. So we talked a little bit about the fact that there's no perfect test to determine ahead of time which operation we need to do. But we can look a little bit to the medical literature in predicting what we think we might encounter, and at least having this conversation ahead of time to give you appropriate expectations as to what the potential success rates are. So in one of these studies, they looked at the chances of having to perform a vasoepididymostomy, the more complicated reconstruction. And what they found was that for every 3 years following the time of vasectomy, there's about a 17% chance of having to do the more specialized reconstruction because of a secondary blockage in one of those tiny tubules. So what this means is that as we get further out from the time of vasectomy, the chance of that secondary blockage does increase a little bit, meaning that we have to identify that and perform the specialized reconstruction called the VE. This still gives us a good chance of having a success if we recognize it at the time of the vasectomy reversal. Certainly, if you've had a vasectomy reversal and we're going to repeat the reconstruction again in hopes of getting a successful result, the chances of us having to go and reconstruct the epididymis, the more specialized procedure, certainly goes up by about 5 or 6 times. Now, in helping us make this decision of which reconstruction to do, some of the older literature looked at just looking at the what we call gross fluid characteristics. So how fluid is it? What is the color of the fluid? Those are some of the factors that we certainly consider. And this is how conventional vasectomy reversals used to be performed. However, nowadays, all the specialized reconstructive surgeons look at the fluid under a microscope and look to see if there's sperm parts or sperm. And as you can see in this paper, doing it this way and looking at the microscopic findings are a lot more predictive in choosing the right operation, which will hopefully result in a successful outcome and a pregnancy. So essentially, this is just a summary table of giving you a little bit of insight to how we look at this situation. And essentially, if we see moving sperm, any sperm at all, or any sperm parts, this really gives us a green light to go with a conventional vasectomy reversal where we put the 2 ends of the tube back together. If we don't see any sperm at all, and the fluid doesn't look particularly healthy, it's a little bit thicker, then this really indicates that there's probably a secondary blockage and we really have to do the vasoepididymostomy or the specialized construction. So what are some of the outcomes with the reversal techniques? A meta-analysis looking at all the studies performed in the surgical literature found that a conventional vasectomy reversal success rate was about 89%. For the VE procedure, the success rates are a little bit lower by convention to the traditional vasectomy reversal and range a fair amount in the literature between 35 and 85%. The ultimate outcome that we're interested in, obviously, is the pregnancy rate. And there's a lot of factors that go into this beyond the reconstructive factors and the male factors. Obviously, the female here is really important part of the equation. However, if we look at all the studies in the surgical literature and average them together, the clinical pregnancy rate is somewhere around 73%. It's really important to have the conversation with your treating physician, however, and determine what the odds are in your particular circumstance. It's fine to have these generalized numbers, but really it comes down to your situation and a lot of the variables that we can use in trying to give you as accurate of a prediction as possible. I often get this question in my clinic: how soon after can we start trying? Well, obviously you want to heal from the operation. Typically by 4 weeks, your tissue has about 70% strength. So after that, we typically say it's okay to begin ejaculating and having intercourse with the aim of getting pregnant. The chance of having sperm come back into the semen after one of these procedures is somewhere between 1.5 and 4.5 months if we perform the conventional vasectomy reversal, where we put the 2 ends of the tube back together. And if we do the more specialized reconstruction, it's somewhere more around 3 months to 6.5 months for sperm to come back into the semen. So we'll typically continue to test this starting about 6 weeks after the operation, every month or every couple months afterwards until we see the sperm coming back. So in summary, fertility experts will always aim to perform a conventional vasectomy reversal whenever that's possible. This is their first choice unless the intraoperative findings give us a reason that we have to perform the more specialized reconstruction called the VE, which indicates that there's an epididymal blockage. We need to get upstream of that so we can reconnect it and ensure the sperm have a free path to get back to the semen. The final point is that the chance of a secondary blockage in the epididymis does increase since the time of vasectomy increases. However, this can be recognized at the time of the operation, and if it is, we perform the more specialized VE procedure for you at that time. Thanks for watching this video. If you'd like more information, feel free to visit my website or the YouTube channel listed here and my Twitter handle below. Thanks very much.